For joining us. We've started recording, so we're gonna get going. And again, thank you so much for being here at this community forum for BIPOC behavioral health in Oregon. So welcome everyone. Again, this event is hosted by the Coalition of Communities of Color. My name is Dr. Mira Mosini, and I'm the senior researcher at the Research Justice Institute, which is a part of the CCC. I'll be moderating the community forum this afternoon, and we're delighted to know that over 340 folks are attending this event. So I wanted to first off begin by recognizing the Oregon Health Authority for funding this statewide research and for their continued support and partnership. We're excited to organize an event like this where we have an opportunity to share the findings and calls to action from the CCC's research on BIPOC behavioral health. We're also happy to organize this event so we can convene leaders from across the state who will share their updates and perspectives on behavioral health. We organized this community forum with the intention of bringing BIPOC community experiences of Oregon's behavioral health system and ideas about how to make these systems and services more culturally and linguistically responsive. We wanted to bring these into dialogue with leaders doing this work. So these leaders who we'll hear from shortly work in community-based organizations and coalitions. They're practitioners. They're working in various capacities in government as legislators, policy advisors, and in health equity. We hope that a public convening like this will foster transparency about the goals, strategies, processes, and investments that folks and organizations are engaged with around behavioral health in our state. We expect that this transparency also translates into powerful and dominant institutions being held accountable by us and our communities. So we'll use the first hour of this forum to hear from our speakers. And as they speak and share their updates, please feel free to ask them questions using the Q&A function. My colleagues will be keeping track of your questions, and we'll use the second part of this forum to answer your questions. The chat function is also available for you to share your thoughts and any updates that you all have. So without further ado, I'd like to invite our first speaker, Marcus Mundy, to come on screen if you're not already and share some welcome remarks. Thank you.
All right. Thank you, Mira. I am on screen, and good afternoon, everybody. My name is Marcus Mundy. I'm the Executive Director of the Coalition of Communities of Color. But before I tell you a little bit more about the coalition, I would like to take a moment and take us through a Native American land acknowledgement, which is very important because we have to honor the people whose land this was and whose land it may wind up being again. Today, I would like to acknowledge the people whose land we are gathered upon. Present-day Portland is located on the traditional village sites of the Multnomah, Wasco, Cowlitz, Cathlamet, Clackamas, bands of Chinook, Tualatin Kalapuya, Molalla, and many, many other tribes who made their homes along the Columbia and Willamette rivers. Let us also acknowledge the robust Native community made up of tribal diversity that originates from around the country and whose journeys have brought them to Portland by ways of forced displacement or seeking opportunities. Today, these same communities celebrate their heritage, showing resilience and tenacity that would be greatly admired by their ancestors. So thank you again for letting us come to you today. I would like to thank OHA again, and particularly the Office of Equity and Inclusion. They were partners with us in this project in lockstep, every step of the way. Shelly Dawson and Leanne Johnson and the entire team there. And I'm glad to see Steve Allen and a bunch of other members of OHA joining us today. So I do want to express that particular thanks to the folks there. The other thing I'd like to do is tell you a little bit about the Coalition of Communities of Color. we are a 19-member, and why we're interested in this project, why we were in the first place. We're a 19-member, culturally specific social justice, economic justice, environmental justice, leadership development, and research justice institute. And we do advocacy also among our things that we focus upon. And I landed last on research justice because we do research so that we can change policy and make it better for everybody in Oregon. So I'm glad to be part of this today. There's nothing more important for us to be talking about today than behavioral and mental health and how its impact manifested itself on these communities of color here in Oregon. If we've learned nothing else in the last 2 years collectively, we understand how important mental health is. We've been hit by fires, by COVID, by unemployment, by unrest in school and our families, isolation, all of that. So I just hope that when you hear from our team of panelists and our partners on this project and our researchers, that you take something back to your organization. So that is it. Without any further ado, I will swing it back, but thank you for letting the coalition share this information. And I look forward to hearing from our researchers and the team at OHA. Thank you.
Thank you, Marcus. I will invite my colleague, Dr. Andres Lopez, to share his video, and then I'll also share my screen.
Thank you, Mira. Good afternoon, everyone. My name is Dr. Andres Lopez. I use he and him pronouns, and I'm the research director of the Coalition of Communities of Color. And I'm so thrilled to be here with you all today. This project has been a labor of love that we have been working on for 2.5 years, I believe. So quite a long time. I want to begin by acknowledging our steering committee, who was made up of BIPOC community leaders, researchers, and service providers across the state, and the various communities of color in which they serve, who were the respondents to the survey, who shared the survey with their communities. It really was a statewide effort. I also want to give special thanks to Kasuma Malamala for her support in this report, in the Black African American and Latinx working groups who are part of the OHA survey modernization process, who are also a big part of this project. So you can read more about those folks in the report. But I wanted to begin with talking about, briefly telling you a little bit about the report and sharing a few slides with you about our findings. Today is really more about listening and hearing from other folks across the state who are engaged in this work and who are taking action towards improving our systems. But I did want to take just a moment to talk about some important things to the report, and I hope that you will download it and read it and consider what it means for you and your organization or your efforts towards providing more culturally and linguistically specific behavioral health support across the state. So first, I just wanted to start with this slide. When we first met with our steering committee, which was at the beginning of 2020, we had them write a love letter, a sort of a love letter and a breakup letter that would sort of talk about the things that they loved about our behavioral health care system and the things that they were fed up with, that they were quite frankly done with. It was really clear to us. We heard loud and clear from our steering committee about the many years. We heard 10+ years of complaints and frustrations from communities saying, we've told you, OHA, we've told you, city, county, state, about what we need, and nothing is changing, right? And there was a lot of frustration about what hasn't changed and about what community has been voicing for years. And I think you'll see a lot of that in the report. But we did also want to acknowledge how things have shifted. And I hope today you'll get even of a better sense of new commitments that organizations and our institutions in Oregon are committed to for more inclusive services for all Oregonians. So I just wanted to share a little bit of this perspective, right? That there is good, there is change, but then there's also frustration and disappointment and time for things to change, right? And so we hold these things together in our research, and I hope that you'll consider and think about that today as you hear about what's coming up for Oregon. Next slide, please. So one of the things that I wanted to share was looking at the most frequently chosen options about what prevents BIPOC community members from seeking mental and behavioral health support. So here you can kind of just get a snapshot of what some of the top concerns were for different community members. And on the side here, you see things like insurance, culture, language, process, and communication. These were really the main themes that came out of our statewide research as to what various community members were experiencing. You can see there's a lot of overlap between the different communities. And this slide isn't meant to sort of say that one community is really specifically set on this concern. I think they all share similar concerns, but it was certainly interesting to hear how some communities prioritized some concerns over others. So there's more details of this in the report. Please check it out and look at it, but wanted to give you a sense of just some of the most frequently chosen options as to why the prevention of mental health services is occurring in our state. Next slide, please. We also asked questions about discrimination and about challenges. We tried not to use words like behavioral health care or mental health care. We used words like, what is stressful, what is challenging, what is keeping you from, or what is keeping you and your family and your children to be able to do the things they want to do, right? We try to use language like that that was more accessible to our communities. But our communities were really clear that they had experienced a great deal of discrimination, shame, dismissiveness, just experiences that really kept them from trusting institutions and trusting more dominant ways in which we provide mental and behavioral health care in our state. So you can sort of see here a lack of empathy, experiences of harmful care practices, and stereotyping by providers. These were things that came up very frequently in how people describe their experiences with our mental and behavioral health care system. So again, there's more in the report, but I wanted to just provide a little flavor here in this setting. Next slide, please. One of the things that, that became clear to us in the research wasn't so much that the state needs to take on just a new targeted strategy to provide X number of trained healthcare workers, even though that is important, mental health care workers. But it was more so about what are the processes in place to make sure that training is effective, to make sure that training provides a permanent position for someone, but that training is connected to a larger strategy, right, of having more structural change around mental and behavioral health in our state. And so we learned that there are some things that are about process, right, that we really have to consider what are the processes in which we provide culturally and linguistically specific services, and not just those outcomes. And some of those processes have to be culturally specific. They have to be led by, understood by, sort of spearheaded by a culturally specific group, right? And some of the processes have to be cross-cultural. They have to be a way in which we can reach different cultural groups where there are similar overlapping experiences, and we can provide that care. And then lastly, some of the processes are really dominant led. And dominant means sort of our dominant institutions in our state. They really do need to handle their own issues and the ways in which they may perpetuate inequalities, right? And they have to lead a lot of that work. And there's a lot of examples in the report that sort of spell out the differences in these areas and shed some light on how we can make some impactful change in our state. So next slide, please. I'm just going to go over some of the recommendations here. Again, this is in the report. I really wanted this time to be for our panelists to share more. But you know, we wrote the recommendations in a way that described, one, the reality of what we were hearing from our communities, and then two, what was the recommendation, right? So we see sort of here about the reality. A lot of BIPOC folks who participated in our survey actually received behavioral health care from religious figures or traditional healers or community-based organizations and clinics, right? Those were go-to spaces for mental and behavioral health, not coordinated care organizations or other more dominant providers, right? Awareness about behavioral health service was a barrier. And we heard a lot about the insufficiencies with translation, right? That we can't just translate something from English to another language, but that we have to have translation paired with culturally relevant understanding, language, perspectives, right, as part of that. BIPOC folks do not utilize behavioral health care services in many ways because there are not enough multilingual and multicultural providers, right? Looking back to the experiences of discrimination, right? Do folks trust that I will be heard, that I won't be shamed, that my perspectives and my family's perspectives or my cultural perspectives about health will be honored, right? And centered in the care that I'm getting. There was lots of low enrollments in CCOs across the state, which you'll see some of the statistics in the report. BIPOC folks experience high rates of racism, discrimination, and bias in medical settings. We can't talk about better culturally and linguistically specific practices without talking about racism. We have to consider what racism and discrimination, how they're manifesting themselves in these systems, and challenge that and provide new ways of addressing that paired with those culturally and linguistically specific strategies. BIPOC needs and experiences cannot be understood without collecting disaggregated, community-informed, and actionable data. So disaggregated data, that is a responsibility of the dominant institutions who are collecting our state's data. They have to do a better job at disaggregating and not erasing communities with smaller numbers or who are not properly engaged in their research. We need community-informed realities, right, that are actionable, that say, this is how the community feels, and this is what we need, right? And we need that data so that we can do better policy, we can do better programming, we can have better long-term strategies. And the last one here, the reality was that Western Anglo-centric assumptions about behavioral health care alienate and harm BIPOC communities. So there are a lot of assumptions about what is proper mental health or behavioral health, right? And the way it should look like. And there's a lot of opportunity to make sense of what that means for folks from different cultures, or what that means for folks with different pressures, or that live in a different context, right? That don't have the same access or the same understanding as maybe some other folks who have better access, better understanding, and maybe even different ways of seeing their own health, right? So you can go to the next slide here, because this next slide here is the recommendations that are paired with those realities. And I'm not going to go through all of these because I just kind of talked through them. But we do walk through these in the recommendation section and provide specific examples in the report where you can see some of that data. So I already have spoken a lot today. I just wanted to share some of these high level pieces with you all. I wanted to thank you and hope that you'll download the report, and really look forward to what our panelists have to say about the report and about how it reflects their own approaches and their own communities. Thank you. I'll hand it back to Mira.
Thank you, Andres. And I would just love to remind folks that if they have any questions, as we're hearing from speakers, please drop your questions in the Q&A. I'd like to now welcome and invite Leanne Johnson, the Director of Equity and Inclusion Division at the Oregon Health Authority.
Thank you so much for the introduction and for the opportunity to be here. My name is Leanne Johnson, Director of the Equity and Inclusion Division for the Oregon Health Authority, she, her, hers. And I'm just pleased seeing the chat and the names come up and the organizations come up, and I'm getting kind of lost in the beauty of that. And also in the beauty of this work and this report. And we'd just very much like to first thank the Coalition of Communities of Color and Marcus Mundy, Executive Director, for the partnership, and the Research Justice Institute and primary researchers, Drs. Lopez and Mosini. And then also special thanks to Shelly Dawson, who is our Equity Policy Director in the Equity and Inclusion Division of the Oregon Health Authority. And Shelly was pushed for this report, and I don't consider myself a smart person, a smartest person, except for this fact that I listen to the smart people around me. And so when Shelly Dawson said we need to do this, I said, okay, yes, we need to do this. So at least I know when to say yes. So we came into this with the goal of gaining a better understanding of what is going on in the system from a person-centered, from a humane perspective, from the people in this state who have experienced or not the behavioral health system. And so our goal is to gain more information in order to improve access for people, and improve utilization of the system, which ultimately will lead to better outcomes. But without correct, proper process, we will not achieve the outcomes. And by the time we see the disparities on paper, it's too late for somebody. That represents it being too late for somebody. And we really are working in the Equity and Inclusion Division and working to guide the Oregon Health Authority towards that understanding. And I am pleased to say that we are feeling that the Oregon Health Authority is being responsive to that. So we have to remember that, I think first and foremost, our society has been is in a resounding denial around racism and around colonization. And this undercuts our ability to envision, to conceive, to develop, to implement deep solutions to systemic racism and systemic oppression and to colonization. And this report, the beauty of this report is that it reinforces in no uncertain terms that people who have been most harmed by the system, meaning tribal communities, Black communities, Indigenous communities, and additional people of color, experience high rates of racism, discrimination, bigotry, and bias in the medical setting. That is just a given. That realization must no longer be one of denial and gaslighting. And this report provides that reinforcement to what we experience day in and day out in our society and in our system. And this is why this report, in part, this is one aspect of the report I will say that's really critical. Those experiences of colonization and those experiences of racism and oppression must drive solution. They must drive a pathway to be sure that we are truly addressing racism and colonization in our system. And that is what OHA is working to do. We are new in that realm across the entire agency, but working to combat that which creates the greatest health inequities in our system. And so we've got to make no mistake about it that those inequities stem from 529 years of colonization, of people, of indigenous people, and of our system. So we must dismantle that, and we must move furthest upstream to address the social determinants of health and the social determinants of equity, which include that racism, discrimination, dehumanization, and cultural insensitivity. That is what's preventing people from getting the care they need and from having the optimal health that we all have a right to have. So we have to step aside as government almost in this proposition. We have to trust the trusted in our communities. We have to make way. We in government do not have the answers. We cannot position ourselves as saviors. We've got to trust the process that is put forward by our communities, our research justice approach that makes way for knowledge and for wisdom and for the expertise of communities, what is paramount. And that is what is represented in this report. And I'm going to close by quoting Shelly Dawson, or maybe paraphrasing Shelly Dawson, the wise person that I have the great honor of working with. And Shelly said, this report, I see myself in it. I see the humanity in it. It is about us. And that's what is so critical. It is about us. And we have got to dismantle those assumptions of Western culture, dismantle Western psychology, and understand that there is an indigenous psychology that is relevant to each and every one of us if we only determined that that is most important to us. So thank you for the qualitative stories and narrative that led to this work, and for the endeavor to be more strategic, more transformative, and most importantly, revolutionary. Thank you so much.
Thank you so much, Leanne. I'd like to invite next Olivia Quiroz, the Executive Director of the Oregon Latino Health Coalition.
Hello, everyone. Nice to see everyone in this virtual space, and I see many colleagues on the chat, so excited to be here. Again, my name is Olivia Quiroz, and I'm the Executive Director at the Oregon Latino Health Coalition. Our mission is driven to eliminate health disparities, and one of those health disparities that's impacting our Latino Latinx community is within the realms of mental behavioral health. I'm also here representing our Latino Emotional Health Collaborative, which is a collaborative that started by many of our leaders and elders in our community to advance and elevate and raise the alarm of mental health disparities in the Latinx community. As well as I'd like to highlight some of the reports and research from our colleagues at the Oregon Commission on Hispanic Affairs. Nuestro Bienestar, a report on Latino mental health in Oregon, which is also highlighted as my colleagues here, Andres Lopez with the CCC mentioned at the beginning of this talk. So it's very exciting to elevate those recommendations. The two questions that were shared and asked of us as panelists to bring back to this group is to talk about the challenges Oregon faces for providing culturally and linguistically responsive behavioral health care. And I'd like to start with, again, elevating the Latino population and our demographics. You've been hearing this for a while, but the Oregon Latinx Latino community is growing. 23% of our youth are enrolled in Oregon public schools that identify as Latino Latinx. And around 17% or 86,000 of these Latinos live in rural communities such as Oregon, Moro, and other eastern rural counties. And so when we look at a statewide strategy, we really got to start thinking about elevating resources that can get to our communities in the rural communities throughout Oregon. But this year and in 2020, it was a difficult year for many of us. The pandemic, again, disproportionately impacted our Latinx community nationally and in the state of Oregon. And we have many youth and many of our families that are mourning the deaths of families that's a result of the devastating pandemic and COVID. But more in particular, I'd like to highlight the barriers within the Latino youth and also the opportunities. Many of our youth that are been impacted not just by the pandemic, by the historical and just generational challenges and systemic layers and oppression and racism that carries on from generation, as well as the stigma that mental and behavioral health is seen in some parts of our culture in our community, in the Latinx here community in the state of Oregon. Many of our youth are impacted in schools. Social remote learning had a disproportionate impact on our youth. And immigration and the rhetoric, anti-immigrant rhetoric and policies that trickle from the federal to the statewide level also poses another layer of stress, and which can lead to prolonged chronic conditions from a mental behavioral standpoint for our families. And one example of that is that families that are separated at the border or multi-generational families with mixed documentation status also have many barriers that our communities face. But going back to the barriers of, overall in our Latinx community, it comes down to the lack of culturally relevant services, long waiting lists for accessing these services if they are available. We talk about interpreters, which creates barriers, and also another big barrier to post between the interpreter and the client and provider. And also that we have a big shortage of bilingual, bicultural providers, and we need to create a better pipeline to foster this next wave of professionals in our community that can able to understand, build trust, and really meet the needs of our community, someone that shares a similar background like us, that we can ensure that we have better methods and services and programs available to communities. And again, from a systemic level, we passed Cover All People in 2021, which is now going to ensure our undocumented adults have access to OHP Medicaid, but it's not right now, it's pending budget, and we know that insurance and mental health services go hand in hand. And so we need to expedite those services. We need to expedite a call to ensure that everyone does receive the services that need, in particular during the pandemic right now. I think that my time is up, but I'll be coming back later in the panel to share a little bit more about recommendations in regards to specific strategies in the Latinx community. And lastly, I like to leave that in Multnomah County and in partnership with the Oregon Health Authority and the Behavioral Health Division, we are partnering to elevate all the recommendations that are coming from these reports, as well to elevate the community voice and needs so that we have the services at the individual, at the community, and at the institutional level. And the Oregon Latino Health Coalition will be reconvening our Latino Emotional Health Collaborative here locally in Multnomah County, which many of the partners here that I'm seeing are participating in that as well. And we're excited to continue to elevate those barriers and partner with other people to ensure the services and that we're meeting the needs of our growing community. So thank you for that, and I'll turn it over to Mira with CCC.
Thank you so much, Olivia. I'd like to now welcome members of the Mental Health Coalition, so Daysi, Lisa, and Coua.
Hi, folks. Hopefully you all can hear me. Good afternoon. I want to, on behalf of the coalition, thank CCC, all of the great panelists here with us, and also all of the participants. Like, wow, over 300 participants, and I see the number ticking up and down, and it's really exciting. I'm going to start by introducing myself, which organization I'm with, and just a little bit about why I'm a part of this mental health coalition. I'll pass it to my colleagues and other coalition members, and then come back to me to give a little background about this new mental health coalition that we've started together. So my name is Coua. I use she, her pronouns, and I'm the Interim Advocacy and Civic Engagement Director at APANO. APANO held an advocacy summit actually right at the beginning of 2020, where it was identified again that mental health is a priority for a lot of our community members. That includes elders, youth, and just general community members that participated in this advocacy summit. It wasn't the first time it was brought up. And so this really is a community identified area for us. And it's a really large area of work that already has a lot of momentum and support. And so we finally come together with PCUN and Family Forward to really start this mental health coalition. So with that, I'll throw it over to my colleagues, either Lisa or Daysi, either one of you.
Thanks, Coua. Hi, everyone. So honored to be here and share the space with you. My name is Lisa Kwon, she, her, and I'm the policy manager at Family Forward Oregon. And we advocate for mothers and caregivers and families and organize our communities to advocate for policies that better the lives of mothers and caregivers. And we really wanted to join this mental health coalition because not just throughout the pandemic, but just in general, women of color specifically bear the brunt of our workforce. And especially with virtual learning and school closures, the mental health of caregivers specifically have been suffering. And so we're going to talk a little bit more about that, but I'll pass it over to Daysi.
Thank you, Lisa. Hi, everyone. So I'm so excited to be here with you all and share a little bit about our work. But my name is Stacey Bedolla Sotelo. My pronouns are she, hers, ella. And I'm the organizing director at PCUN. And we have organized and empowered farm workers and Latinx working families for over 3 decades. And, you know, part of why we are part of the Health Coalition, it's because it's such an important issue and such an important topic to all of our communities. I know that some folks have already mentioned that the stigma that's around, and I think it's very important. And we all believe that, you know, we need to start looking at our folks and our communities as a whole, not just as physical or, you know, other aspects, but really look at our communities as a whole. So with that, I'll hand it over to Coua.
Great. So I will just give a little blurb about our coalition. So APANO, PCUN, and Family Forward, we've come together to form this, this new coalition to create an effective health justice advocacy campaign across our organizations. Communities we collectively organize, including mothers, caregivers, immigrants, refugees, farm workers. We all have always lacked access to healthcare and mental health care services. During this time, as a result of increased hate crimes and incidences of racial violence, the COVID pandemic, and the economic recession, we are really finding ways together to elevate the need for mental health care support services. So I will just quickly highlight the parts of that report that we have also heard come up from community conversations, including listening sessions, youth and member conversations, and healing circles as well between our organizations. So stigma that you all have heard that come up multiple times, and the cultural perception of mental health. I think across our organizations, there is that stigma, right? And different cultural practices view mental health differently. And that includes like fear of retaliation from your community, your workplace, right? And when you identify that you are needing mental health care, then also judgment. And the need for disaggregated data has also come up multiple times. And I think at APANO, like what we think of, right, is like the the erasure of communities from healthcare. And so that for at APANO, we think about Pacific Islanders, Southeast Asians, but that's not all of it, right? Like that's not the erasure, like so many communities are erased from healthcare access. And so that is a huge thing. Accessibility, you all have also heard and will probably continue hearing throughout this forum. And that's not just language though, it's also like accessibility to healthcare, to health insurance. Folks don't have, access to those things. So how are they, able to access care? And then also like technology. And so during COVID, when everything is, this forum is on Zoom. And so if you don't have access to technology, to internet, right, that is also a barrier. And then lastly, I want to uplift from the report as well, the lack of trust with medical staff due to medical racism. That's really real. And that's what we've heard through our conversations directly with community members as well. And I'm going to pass it to Lisa to go over some of the, action items that we have been working on, we'll continue to work on as a coalition.
Thanks, Coua. So kind of to shift to the policy and legislative side of what our coalition has been working on, we supported House Bill 2949 from the last legislative session, which was a big part of a big behavioral health workforce package. And this was really important to us because of what Coua mentioned about our communities needing services from people who look like us. This legislative session, we are supporting House Bill 4004, which is a bill that provides more additional assistance, financial support to behavioral health providers while the bigger pot of money is coming. And we really wanted to emphasize and highlight how we view our mental health advocacy. We believe that there are so many intersectional and systemic issues that we have to address at the same time, which is why we support issues like farm worker overtime and universal legal representation for immigrants, and transforming our public safety system. Because like I think what Olivia mentioned earlier, mental health is not just a clinical issue. Immigration and not having farm worker overtime really is detrimental to the mental health of our communities. And so this work is really long-term, and we're going to need long-term funding to address these systemic issues, which is why the work needs to come from the community. So thank you all for listening to us, and we'd love to connect with you all to continue our work together.
Thank you so much, Daysi, Lisa, and Coua. I just want to make sure that y'all have said what you wanted to say. Yeah. Okay, great. I just wanted to remind speakers again. We have our interpreters with us. If you could speak a little bit more slowly, so that we make sure the interpreters can catch everything. So appreciate that. All right, thank you so much, representatives from the Mental Health Coalition. Next, I'd like to invite Janelle Joseph, Executive Director of the Native Wellness Institute. Thank you.
Thank you. Hi, everyone. As Mira said, my name is Janelle Joseph, and I am from the A'ani people. That's what we call ourselves in my language, which means white clay. And I'm the executive director of the Native Wellness Institute. We are a national, I like to call us a social profit organization. The IRS calls us a nonprofit organization, and we're based here in Oregon. And we serve tribes and urban Native programs around the state and around the nation. I'm also here representing the community engagement arm of the Future Generations Collaborative. And I'm also here as a member of the Oregon-based BIPOC Decolonizing Data Council. So I wear many hats like many of us do. And there's so much I want to talk about. So first, when we talk about challenges in behavioral health programs. You know, I always like to remind people that our mental well-being is connected to our physical well-being, which is also connected to our emotional well-being, which is also connected to our spiritual well-being. And so, you know, they're all connected, and together, you know, it creates the circle of who we are, right? So I want to start out with that, because that leads to the challenges. So there's challenges at different levels. And so us as individual tribal people, we know that we have a responsibility to live in balance, right? To live in balance between our physical, mental, emotional, and spiritual well-being. And so part of that is by learning about the lasting impacts of colonization and how colonialism is another ism that continues to play out today, just like racism and classism and sexism. And when we have a profound understanding of how that trauma continues to play out, we can better understand ourselves and our family members and our community members. And we can begin breaking through some of the lasting rules that still trickle down from trauma. So for example, don't talk, don't trust, don't feel. And we know that where there has been trauma, healing is the answer. So we have to oftentimes do our own work to break through those 3 unspoken rules so we can begin our own healing journeys, right? To better live in balance. So that's kind of like one level of some of the challenges. And we're doing that work in tribal communities for decades and decades. We have been doing that work. Back in the 1980s is when we got the term historical trauma, right? And that helped us to articulate our experience as tribal people. And when we were able to articulate it and explain it and describe it, then that helped us to better like understand and connect the dots and help ourselves along the healing journey. So we have a long ways to go, and we know that because hundreds and hundreds of years has produced some of the unbalance that we see in our communities today. And realistically, we know that it's going to take a long time to do the healing to move through that. So that's one level. Interestingly, you know, during the pandemic, and I love one of the quotes in the report, it talked from a Native woman, a Native person, and it said that one of the things that she felt this pandemic brought was an understanding of how genocidal practices in our historical past have impacted our people, like biological warfare, for example. And if you know anything about smallpox and how other diseases were passed in our community, she was relating COVID to that. Like now everybody else gets to understand what it feels like to live in a pandemic, right? And so when the pandemic hit, we knew that an already traumatized people would be re-traumatized during this pandemic. And right away we saw that the calls and texts started coming in. And we responded because just like there's historical trauma, there's the flip side of that is historical wisdom, right? And that historical wisdom allowed us to come together and step up and be of service to our people. And that's what we did. You know, we became Zoom warriors and we were of service to our people. And so with funding from OHA and other places that were coming forward without even us asking and saying, hey, we have this funding, what can we do, you know, to help? Or here's this funding here, please, you know, serve your communities. And I want to give pay respect and homage to, you know, this whole, you know, social justice revolution that has been happening, right? And the Black and brown people that have been killed that we have watched, you know, on TV happen, and Portland being an epicenter of this revolution, and how it's made people like stop in their tracks and open their eyes and open their hearts and saying, oh my gosh, like, you know, what can we do? And the funding coming in for us to better serve our communities. So becoming Zoom warriors was about helping our people to connect, right? Because we weren't able to connect physically, right? And I'm wearing my, I don't know if you can see it, my social distance champion shirt today, my Bigfoot on my shirt, but we're used to being social people, right? So we had to come online, and I just want to give a shout out to our workers. In the past year, we made 2,925 deliveries for our online community support circles. So I just want to give a shout out. So we're doing our healing in our communities, and we know how to do that. And the systems that we work with also have to do their healing. You know, part of our behavioral and mental health challenges are also navigating racism and oppression. So white people need to heal and do their healing work too. That's the other part of the equation that is oftentimes missing. And I want to be sure to say that. So we know that where there has been trauma, healing is the answer. In my world, it's like the answer to everything. And so that's what I want to bring here too, is when we look at the behavioral health programming, how are we integrating healing into that? And how are we helping others to embrace those thoughts around there? And I'll be here for the Q&A after. So I want to thank everyone for this opportunity, and I encourage everyone to read the report. All right, thanks.
Thank you so much, Jillene. And very, very glad that you mentioned Q&A. Many of our panelists will be here for Q&A. Again, just wanted to remind everyone here that you can drop your questions in the Q&A using the Q&A function. So next, I'd like to welcome Alfonso Ramirez, Behavioral Health, Equity, and Community Partnership Director at the Oregon Health Authority.
Hi, good afternoon. Alfonso Ramirez. I use he, him pronouns. Buenas tardes. Me llamo Alfonso Ramirez. Mi pronombre es él. And I just want to thank OEI, Shelly Dawson, Leanne Johnson for all the work that they've been doing, and the coalition of communities of color for their work and the specialty they've developed in this type of health equity research. I am in a new position of behavioral health equity and community partnership. And I had worked at the OHA before, and I didn't think I'd come back, but seeing the changes at OHA and the desire to be led by those with lived experience, especially those most impacted by health inequity, was a noble cause that I wanted to be a part of. I'd like to share my screen for a second and talk a little bit about what we have been trying to do over at the Oregon Health Authority. And we can think about health inequity or our health systems as kind of an iceberg. And at the top, we have these outcomes that most of us can see and which are so well highlighted here in this report. And, in the past, we've always tried to, change our actions, maybe change the services, change payment methodologies, but we really haven't done much to change the experiences that people have. And I think deeper below the water are sort of the discourses that we're having and the beliefs and biases that are just innate in our systems. And so what I appreciated about this report is it affirmed a lot of experiences that I've had as a Latino male, and also what I've been hearing from community. And the challenge for us really is, how do we overcome our biases, and how do we have communities of color help us design these systems that we're creating or that we co-create together, and how do we allow them to help us shape the discourses, the actions, or even what the outcomes should be? And for me, those are really about listening ourselves to learn and to heal ourselves, to ask questions, to be reflective and responsive, and really to share with humility that we don't have all the answers, and that there is cultural medicine in the community. So that's really the part that I think we can really grow and develop and develop wisdom in collaboration with communities of color and true partnership. I think a lot of what's been said today has been really broadening for me in terms of my perspective, understanding the mismatch of services, and that mental health is an experience that that isn't captured in our current behavioral health sort of box that we have for many people. And it's in particularly, I was really intrigued by the idea of like, how do we measure wellness? And what I know is that we need to do that in partnership with our communities. So just thank you very much to the Coalition of Communities of Color and to all those that participated in OEI, and appreciate your time.
Thank you so much, Alfonso. Our next speaker is unfortunately not able to join us in person, State Representative Tana Sanchez, who represents Oregon House District 43. However, she did provide us with a written statement, which I'm going to read. And so I'm going to share my screen. And also start my video. Good afternoon. First of all, I would ask you to please accept my sincerest apologies for not being able to be with you today. Behavioral health is my highest priority, and I'm so very excited about the work that the coalition has done to shed an amazing light on the subject of communities of color. I'm also excited about my new role, brand new, as co-chair of the Ways and Means Committee at the legislature, where I can support this work. One of my bill priorities this session is House Bill 4102, which would create a position within the Oregon State Police, OSP, the Tribal Relations Liaison. This person would serve as a centralized contact person for all 9 federally recognized tribes and Native people to improve OSP policy and procedures. My second priority bill, House Bill 4098, would ensure that the Alcohol Drug Policy Commission, ADPC, would work with a more comprehensive set of state policies, in addition to providing more reporting annually on that progress. This is important in terms of implementing the state strategic plan to combat drug and alcohol addiction and shed light on a problem that is often ignored by Oregon policymakers. Creation of this liaison would result in developing standard reporting protocols for each tribal government and urban Native communities, and would define who and when to call and what to expect during the investigative process, such as how to file a report to law enforcement, what law enforcement is required to do when a report is filed, what the public gets to know during and after investigations occur, what the medical examiner's role is regarding investigations, and how to challenge a reported cause or manner of death. Following behavioral health through all of our communities and pushing this money out the door for people who are struggling, particularly for people who suffer from inadequate care or tragically suffer death or injury from encounters with law enforcement when mobile crisis could have avoided that outcome. During the 2021 session, and now I am also concerned with the workforce crisis and the importance of not only getting people in the room, but encouraging people of color to enter the field of behavioral health so that cultural competency can be improved. Here are a list of bills from the 2021 session that are continuing to be implemented, and I'm committed to making sure the money gets out the door and put to work. Increasing diversity in behavioral health programs, House Bill 2086, that appropriates over 10 million for programs that are directly responsive to and driven by people of color, tribal communities, and people of lived experience that are peer and community driven and that provide culturally specific services, and for medical assistance, reimbursement of tribal-based practices. Mobile Crisis Response /988 call system, HB 2417, that directs OHA to provide 10 million in grants to cities or funding to county community mental health programs, CMHPs, to fund mobile crisis intervention teams, and establishes a statewide system of crisis response linked to a 988 call center and the systems and services to support the hotline, including a mobile crisis response units mentioned, crisis stabilization, and follow-up care for Oregonians experiencing behavioral health crises. Behavioral Health Workforce, HB 2949, that directs OHA to provide 110 million in incentives to increase recruitment and retention of behavioral health providers with associate, bachelor's, master's, or doctoral degrees, or other credentials who are people of color, tribal members, or residents of rural areas in the state. Peer respite programs, HB 2980, that directs OHA to provide funding to peer-run organizations to operate 3 peer respite centers, allocating $4.5 million. Thanks again for attending today and for the work that you do every day. Please know that I work with you in spirit and that the fight continues. Please feel free to follow up with my office regarding any questions or comments you have. Mira speaking now. I will post Representative Sanchez email in the chat. Again, Representative Sanchez, sincerely, Tana Sanchez. As I welcome the next speaker, I will be sure to post the representative's email into the chat. And again, feel free to be in touch with Representative Sanchez if you have any follow-up questions. So next, I'd like to welcome Jackie Yerby, Policy Advisor for Behavioral Health and Health Licensing at the Office of Governor Kate Brown.
Thank you so much, Mira, and thank you to everybody at the Coalition of Communities of Color and everybody who participated in putting this amazing report together. And special thanks to the folks at OHA as well. Borrowing Leanne's quote of Shelly, I see myself seen in this report. I am a mixed race woman. I identify as Thai American, Asian American, as well as a Black American. And my mother is a first generation immigrant to this country. And I was that kid who helped my mother navigate the healthcare system and continues to help my mother navigate the healthcare system, including what we understand to be the behavioral health system. And so I'm well aware of the challenges of doing that and finding culturally responsive care. And I should also say, I've also had that experience of navigating that system for myself and finding culturally responsive care. And I'm somebody with a lot of privilege and very good health insurance, and just feel incredibly fortunate that I was able to find a therapist, a licensed clinical social worker who is a Black woman to just accompany and support me through challenges that I've had. And so I just know how incredibly important it is for being able to access services where they feel seen and heard and understood. And I'm so grateful that I get to work with Representative Tana Sanchez, who incidentally is also my representative in Northeast Portland, and with Director Steve Allen at the Oregon Health Authority and his team, as well as with Olivia Quiroz and Ellie Bello and just a whole bunch of other people on behavioral health and health equity. So I am Jackie Yerby. My pronouns are she, her. And as Mira mentioned, I am the policy advisor for behavioral health and health licensing for Governor Kate Brown. And just so many things about this report resonated with me, but and you know, you heard a little bit from Rep. Sanchez about the bills. You will probably be hearing more from Steve Allen about specifically what they're going to do. So I will talk about, I think, specific linkages that I saw where I in my role could make a difference. So again, this is an amazing report that I just want so many more people to hear about. And so I work with the health licensing boards. And I can't remember the legislation, but legislation passed requiring health licensees to get training in culturally competent care. And that is great. And it also makes me incredibly nervous because I don't know where they're getting their training. And so, you know, I would love to talk more with this group about what does it look like to make sure that our health licensees, you know, everything from physicians and naturopaths and nurses, I mean, just the whole spectrum, dentists, our behavioral health care providers, that they are getting the kind of training that we feel good about, that is not actually going to perpetuate harm or make the situation worse. So that's one thing. And then I think a way to start that conversation is that the executive directors of the health licensing boards meet every other month. They just had their meeting in January, so they'll be meeting again in March. But I would love for some folks to come and present to that group about this report and just kind of spur their thinking and get that conversation going. You know, I also think about, you know, how important it is to build the pipeline. And I saw somebody in the Q&A ask that question about where do you get started? And I don't know that I can necessarily answer the where do you get started, but I would love to also connect this group with some of the professional associations. And I'm thinking about COPACT, which I can't remember what that stands for, but it's basically the Counselors and Therapists Association, to talk about this report and again, like build those connections and start that conversation. You know, just thinking about connecting with the folks at OHA who work most closely with the CCOs, like let's get this report in front of them so that they understand like all the different ways that our communities understand. I'll use the term behavioral health, and we'll pause and say, I so appreciate how this report like frames behavioral health and mental health and some important learnings for us in state government about how we talk about it. So that's a conversation that I want to pursue with Steve and his team offline. But again, just trying to make those connections so that our payers, CCOs, and I would say even beyond them to the commercial insurance companies, recognize that community is receiving care in lots of different ways. And what do they need to do to step into that space so that people can actually make a living providing that care and that the people who need it can actually access it. So those were the main things that came to mind for me. Just again, so much appreciation for this work, so much appreciation for just the idea of research justice. I remember when I first learned about it, I just felt like, wow, like my mind was flown in a really good way. And I think that we need to continue bringing this idea of research justice into lots of different spaces so that we honor people with lived experience, you know, kind of, and just the depth of their knowledge, and just, you know, recognize the value of cultural medicine, which unfortunately I don't think that our kind of Western Anglo culture appreciates, or maybe they've lost touch with it, and we need to help them reconnect with that. So those are the things that, actually one other thing that comes to mind, kind of building off what Lisa and others had talked about in terms of this coming session, and just looking back a little bit at the last session. So working with Representative Sanchez, we were able to get $350 million in behavioral health investments, and that is groundbreaking, and in some ways a drop in the bucket in terms of what the need is. And so legislative session ended at June 30th, and I don't know if you remember, end of June, early July, we were happy, we were hugging. Some of us, we even, you know, took off our masks for a little bit. And then Delta happened, and just exacerbated lots of things, including the behavioral health workforce crisis. And so we got a lot of pressure to spend the money now, to fix the workforce crisis now. And, you know, I, Steve Allen, other folks were like, yes, but equity. And it felt like we were trying to, there was some trade-off between, well, we've got a workforce crisis now, and, you know, we'll deal with equity later. And thankfully, because of a positive economic outlook, we were able to maintain those investments. But that said, I think it's really important that legislators hear from you, hear from folks in the community, how important it is to center equity in what we do in behavioral health going forward, how important it is to preserve the money that they invested from the 2021 session to make sure that we're able to provide culturally responsive care to Oregonians who too long have been kind of left out and left behind. So, you know, I may be reaching out to you to say, hey, could really use your support in going and talking to legislators about how important this is to you. So thank you again, just really honored to be here with all of you.
Thank you so much, Jackie. I would like to invite our next and final speaker, Steve Allen, Behavioral Health Director at the Oregon Health Authority.
Thank you. So lots of great information today. I just want to start out in my remarks thanking the coalition and especially the steering committee and all who had a hand in creating this report. It's extraordinary. And I think the timing could not be better for this report because it can be and will be used to inform the transformation work that we're working on. And I mean that in two ways. One is based on the research from this report, there's insights within the data, both quantitative and qualitative, that I think will be extraordinarily useful. But for me, I think what's more important is the way that this document and this research was done, and that's all about the process. And I think we've been charged with transforming the behavioral health system, and that's because it's not working all that well. And I think it's not working all that well even for white dominant culture. And we've been asked, based on our engagement with community, to take a look at, you know, what's underneath that, and to look at the system as it is even at the molecular level. And I think for me, what that means is looking at the beliefs, the biases, the assumptions, the values, the philosophies, the research that helped shape and form the system that we have. But I think as importantly as all those things is to recognize the power. So whose biases, whose beliefs, whose assumptions, whose values, whose philosophies, and whose research were driving how this system that we are currently living with was created. And I think a radical transformation is to begin to reshape. And I think underneath that, the system that we have, I think, is an inherent lack of trust in community. It's a system that I think too often looks at what the providers and the systems that we have think is good for you, rather than listening to the wisdom and empowering the wisdom of community to really drive what the system of care ought to be. And this research that we have here and the process that was used to create it is deeply embedded in revising and transforming how we think about engaging with community to inform practice. And I think that's incredibly powerful and incredibly valuable. And so just want to take my hat off to all who were involved in it, because I think this is truly transformational work, and it points towards how the process of transformation can move forward. And finally, I have a minute left. So finally, just want to hats off to Representative Sanchez and to Jackie Yerby, who has been a relentless advocate for system change. So thank you all, and appreciate this opportunity to be a part of this.
Thank you so much, Steve. And thank you so much, immense thank you to all of our panelists and speakers who have shared their experiences, their knowledge, and their work in this space of behavioral health. And it's been, you know, hosting a forum like this is really the first time that we're doing a community forum like this as a way of sharing and circulating research, and having that be in dialogue with your experiences. And I also noticed that folks are sharing updates and experiences of those who are attending, and I greatly appreciate your engagement and your continued dialogue with us and with this incredibly important topic. So with that, I'd like to move us into the question and answer portion of this forum. We've been getting a lot of great questions, and my colleagues and I have been kind of talking in the background, figuring out which ones to ask. And we noticed there was quite a few questions around what is happening around the state in policy areas at organizational levels relating to substance use disorder and addiction. So my question to the panelists is, how are organizations and institutions here supporting treatment and recovery of addiction or substance abuse disorder? In other words, what are you doing right now to make meaningful changes? What can be done to help? And this is to any panelists who'd like to answer.
Too. Hey, Steve, you're on mute.
Oh, sorry. I think I'd be happy to start an answer. I think one of the more interesting and I think impactful changes in addiction services here in Oregon is the work being done by the Oversight and Accountability Council in Measure 110. So that's a group that is selected based on lived experience. And that group, if you've had an opportunity to observe them, and all their meetings are public and are recorded, I think their process is truly transformational. And there's $300 million that they've been allocated that they are now investing in services that will be transformational, both in terms of being able to have more services available to people, but designed for people who are struggling with addiction. So I think that's really important work, and hope people are paying attention to that.
Thank you, Steve. Would any of our other panelists like to comment about what's happening around substance abuse recovery and treatment specifically?
I kind of speaking personally as a former staffer of Rep Sanchez, I've learned a lot about addiction and recovery through her. And I just want to uplift the bills that she mentioned. Last session, there was a bill related to mobile crisis response. And she's also working on 988, which is Oregon's own hotline system. And so although those don't directly address addiction recovery from the community level that I'm working on, I think Rep Sanchez is an amazing champion. And I think we should, again, let folks that are directly impacted from that issue lead. I think Jackie has her hand up.
Thank you, Lisa, and thank you for mentioning 988. The 988 is basically like 911, but it will focus on behavioral health, mental health, SUD, people experiencing crises, and it's going live this July. It'll be a national number. So right now, there's a 10-digit number, which as many times as I've heard it, I should remember it. I don't. But so we're hoping that 988 will be this easy number for folks to remember. And as I can't remember, maybe it was Rep Sanchez's letter talked about, it's not just the phone number, but it's also, mobile crisis response, a trauma-informed mobile crisis response, so that, so that somebody who has experienced a crisis comes out of that encounter alive. For one thing, unfortunately, us folks, especially here in Portland, have heard too many stories of somebody experiencing a mental health crisis and who doesn't survive an encounter with the police. And we absolutely need to shift that. So OHA folks are working really hard on 988. It's not going to be, flip a switch in July and it'll be amazing, but it's going to be good and it's going to get better. So really excited about that. And I think it'll have like disproportionate benefits to communities of color.
Thank you, Jackie and Lisa, for your responses to that question. We have another question, again, to all the panelists. How does someone that works in a dominant culture organization in a leadership role advocate for culture's change internally to address health inequities? DEI initiatives can be extremely performative, and it's more harmful than helpful. So I'm curious if there are suggestions for first steps to push for change.
Yeah, I can take talk to that a little bit. I think there are three things that I think a leader can do. One of them is really to develop that sort of critical consciousness of like what people experience. What does health inequity look like, or inequity in general, and provide people opportunities to have those conversations. And this report is an excellent starting point for those conversations. And I think the second thing that isn't always sort of thought of is really, how do we humanize our cultures? Many of the work environments that we're in are very stressful, particularly for people of color. And how do we create different ways of working that is more collective in our thinking? And the last thing I would say is really as a community to come up with practices and to partner with other people around practices that help support thinking and decisions related to equity.
And I'd like to jump in and comment as well. So I feel that DEI, diversity, equity, and inclusion needs to be turned on its head, because we know that most often DEI is code for, you know, a person of color in that position. And then to address racism and oppression, that's put on their shoulders, right? So by flipping on its head, I mean that I think white people need to be in those positions, and white people need to help other white people to heal. And that will address part of the challenge, because what happens often is, whether it's a tribe or a Native organization or any organization, oftentimes people of color, BIPOC folks come in and come out, come in and come out, like a revolving door, right? And then non-BIPOC folks are wondering, like, see, they can't hold down a job, or, you know, we're you know, all of this kind of stuff, but they don't understand how oftentimes workplaces are described by BIPOC folks, and sometimes words like toxic, you know, unhealthy, that's how BIPOC folks describe it. And non-BIPOC folks may describe their workplace as the best place I've ever worked before. So there's this huge divide there, right? So I'll say that much right now.
Yes, Leanne.
Oh, yes, thank you. So yes, I don't have much more to add. And part of it depends on what kind of an organization. And if it's an organization that is intended to be of service to people, especially government entity of service to people, that involving community early on is critical. I would say that especially in government, that our greatest ideas and greatest successes came from community. Somebody early on from APANO spoke about the race, ethnicity, language, disability disaggregation, and APANO was one of the primary partners in that. So the push from community and from the people, especially when it relates to a government entity, is absolutely important for not only for the ideas and the work and the following the lead of, but also for the checks and balances and for the accountability as well, which is critical. And I will just end by saying, at one point in time, our work was at risk by internal forces, and it was external forces. It was community that went to the legislature and saved us. So never, ever, ever think that that we have all the answers internally, or that we have to work this through our internal before we go out there and do the external thing. And there's vulnerability in that courage to do that, and that will pay off in success when community comes forward when you need them most. And even when you don't need them, because they will hold you accountable sometimes to the point where you think enough is enough. But that piece, we cannot survive without that connection and making way for that wisdom.
Thank you so much, Leanne, for that, and for others for sharing your perspective on what is so critical to this, to materializing many of our recommendations around, you know, how to affect institutional and structural change. I wanted to ask panelists a question around workforce. For obvious reasons, that is critical to investments in culturally and linguistically responsive care. So the question is, how do we get organizations to prioritize hiring and retaining BIPOC mental health providers rather than cultural specific training of non-BIPOC mental health providers? And a follow-up to that question is, are there any examples of how we plan on growing the mental and behavioral health workforce to address many of the needs that were brought up in this report?
I can take make sure I'm off mute this time. I can take a first run at that. So Representative Bynum's bill 2949 allocated $80 million towards increasing and diversifying behavioral health workforce as a focus. And we are moving towards implementing that legislation and informed and directed by individuals from our communities of color. So we're not just using the same pathways to get money out the door that we have in the past, because frankly, if you look at the outcomes of that effort, it has not increased diversity. It's doing things differently than we've done in the past that we think will lead to transformation. So that work is currently ongoing. Another thing I think are interested in is if we think about the skills, the approach, the background, the experience that really makes a difference in working with people from our communities of color is those who really understand it. Being able to speak multiple languages, having expertise from a particular community is valuable. It's incredibly impactful when those individuals can do that work with their communities. And so I think it's appropriate to consider rates of pay that take into consideration those additional that knowledge, skill, and ability, and paying more for that. And so I think that could be another approach in addition to the other work that's being done that can help recruit, retain, and value a diverse workforce.
Mira.
Marcus.
Yeah, I have a couple of comments on that. I agree with much of what Mr. Allen said. And also the healthcare entities or the government entities, whoever's hiring these potential providers of color, also need some self-reflection. They need to analyze who they have now, what their existing numbers are. There's been studies done of the hospital systems here in Oregon, and their workforces kind of sort of approximate communities of color, but they push most of their workforce into the either entry-level jobs or culinary or housekeeping, or they push people into those disciplines. So they might have numbers that match what they need for EEOC, but they're not matching what the community needs in real healthcare. So they have to first know what their internal numbers are. So do some analysis and see where they are. And then they can't interview and intake, Steve mentioned this a little bit, in the same old way. You have to have diverse panels of interviewers that can not just hire the same old people. You know, most of the managers and supervisors at these institutions, both the governments and the healthcare systems, the higher level folks are the dominant culture, are non-people of color. And so you have to diversify your interview panels. You have to de-identify the names sometimes to get rid of those biases. There's a lot of tools you can use, but then you also have to go to the root of the root, which is in the school systems, and let them know about these careers and that these are living wage careers and certain pathways that they need. So there's a lot of ways to get there, but you have to be willing to change. And someone on the team, both the last question they asked about how they can diversify the workforce and this current question, power concedes nothing without a demand. Frederick Douglass said that. So you have to ask the questions about why we do not have a workforce that approximates the patients we see, and then take the steps from there. So that's my diatribe, but thanks for letting me share, Mira.
Jackie, go ahead.
Yeah, I'm gonna like so many snaps for you, Marcus. Something else that occurs to me is and I can't remember if it was Alfonso or somebody else spoke to kind of the workplace culture. So what is it? What are the environments that we are hiring people into? And so if that work environment isn't sort of welcoming and supportive of somebody from a diverse background or maybe doesn't value it, then I worry, like, is that organization going to be able to retain that person, or is that person going into a workplace that's potentially unsafe or toxic for them? or just, you know, kind of bottom line, not supportive. So it just feels like there's a lot of work that organizations need to do in order to be places where folks of color actually want to work, and can feel like they can do their best work. And there's, you know, not an easy solution to that, but that just feels like a really important piece of it. And then I'll just echo the, you know, what Marcus said about the power not conceding without a demand. Yeah, and and so I just think about, like, are there stakeholders out there who can say, hey, we need to see this or else? One other thing I will say, House Bill 3046 from the last legislative session is on mental health parity. And so Department of Consumer and Business Services has to gather data around network adequacy. And part of that is around diversity. And so that's another way that we can try to get at, you know, making sure that, or as a start, recognizing that we don't have the providers that we need in place.
Thank you, Jackie. Lisa.
Thank you. I wanted to add to what Steve Allen mentioned about House Bill 2949. Our coalition is lucky to participate in OHA's Community Leadership Council to decide how the funding from 2949 is actually spent. And I think it's really important to address the external factors of what folks in the behavioral health workforce are experiencing. So tuition aid, for student loan forgiveness, housing, childcare assistance are all included in the bill. And I think it's really important to address the barriers that are keeping behavioral health folks, especially people who are from communities of color, addressing the barriers they have in the first place. And so I think it's really important to be intentional about the funding and how that is being funneled.
Thank you, Lisa. Actually, this is a good segue to my next question, because I wanted to ask, and this would be first directed at folks that work at community-based organizations and coalitions that are, serving BIPOC populations more or less directly. So what do community-based organizations need to further support this work? What do dominant organizations like OHA, like the legislature, what do they need to know when making decisions about behavioral health initiatives?
I can speak a little bit on it. As the Mental Health Coalition, I think we have done our internal research as well as to what is available and what other people are doing. But there is no secret that there will need to be a continuous funding, long-term funding, right? We're talking about all of these bills, all of this money, which is great, but how do we look at, emotional health, mental health in the next 10 years, right? This is not going to be something that it's going to be fixed in a month, in 2 months. And I think there also from these organizations, we need to see plans, right? So when we hit another pandemic, what does behavioral health look like? So that when we are hitting emergency, any emergencies really, we've seen the wildfires, we've seen other things that have affected our BIPOC communities. So what does that look like for our communities and what access is available? I think another thing would be analysis of what we already have, right? And also always checking in with community-based organizations, because a lot of the times they're already doing the work, right? So how can we support what it's already being done or has been done for years, and making sure that it's open and accessible to those communities, those not only the communities, but also the folks that are doing the work. And also, it's great that we wanna work, but we also have to look at the capacity that everyone has. During the pandemic, we've all been asked to stretch ourselves, and that's just the reality of the pandemic, right? So what does that look like for other organizations? How can you all step in and say, you know what, I will take this and I will help this way, right? There, rather than asking and just like having all of these questions, a lot of the times it's better to just be like, here's, I don't know, an X amount of money, you know, use it however you want and however you think your community is going to be able to receive those resources. Another piece also is when we're talking about language accessibility, there's, we saw a question in the chat, right? Not only talking about English and Spanish, but also indigenous languages, and seeing that how our communities are growing, and doing all of that analysis as well, which, you know, the report also talks about language accessibility, but also technology accessibility, right? Internet accessibility, phone, whatever it is. So when we're talking about accessibility, not just talking about one specific issue, because then we can address all the other issues and really understanding where our communities are coming from. Because we can sit here and say, you know, BIPOC communities do not want to get mental health. And the reality is, no, that's not the case. There's other barriers as well that we have to understand, you know, health accessibility as well. So all other issues that we have to be able to address to make sure that we're looking at people as a whole.
Thank you so much for that, Daysi. Would anyone else like to share perspectives on like what, you know, what is it that communities need decision makers and those with resources to know?
Well, I think one of the blessings of COVID, and there have been many blessings, was the funding that came about and how fast that happened, and how, in some cases, how easy that happened. And what it showed was that it can be done, right? We didn't need to submit 100-page proposals on to do XYZ, right? Like we had to submit sometimes a 1-page, you know, application. And so a new norm has been set. And I think the success of that, like the announcements coming out, the deadlines ending quickly, the money getting out quickly, and then boom, we could hit the ground running to do what we needed to do. So I think funders and people, you know, leaders need to take a look at that. I think another one related to how we look at behavioral health in our communities and what are the answers, especially when, like when you talk to young people, our young people have really suffered through this pandemic, right? And now we're coming upon, there's already people talking about, you know, instead of PTSD, we're going to have PCSD, post-COVID stress disorder. And how are we going to be prepared to deal with that when we do start coming together, right? And then also related to our young people, this whole virtual reality, the whole VR thing, like we need to be prepared now for that, especially us from, you know, older generations. We need to be prepared now for that, and how that's going to impact, you know, the behavioral health of our young people, especially. And then keeping in mind that, you know, our physical, mental, emotional, and spiritual well-being are all connected and are all tied. And so sometimes the solutions are going to look very differently that might not be, you know, considered behavioral in the behavioral health, you know, realm. So just to be open-minded about that.
Thank you so much, Jillene. Before I ask my next to final question, I wanted to just remind folks here about the recommendations in the report. I know Andres went over some of them, but let me just remind you that there were recommendations around building a BIPOC workforce. There were recommendations around investing in culturally and linguistically responsive outreach to BIPOC communities, especially those living outside of metro urban areas. we saw in the report that CCO enrollment is very, very low for BIPOC folks, and particularly those living outside the metro areas. So how do we invest in those types of outreach? Or I should say investing in outreach is the recommendation, is the action. Investing in culturally responsive training, we touched on this, right, around issues of cultural and institutional change, deferring to and partnering with and compensating trusted leaders and BIPOC serving organizations. As we heard in the report, many BIPOC folks seek mental and behavioral health care outside of institutions, big and dominant institutions. They seek out faith leaders and their community members. So my question to the panelists is that how what resources exist both in dominant institutions at OHA? For instance, what resources exist that can be deployed to address these recommendations? How are you going to address these recommendations? How are you going to secure additional funding and really support the recommendations in this report? And part B of that question is, from a community perspective, how should these recommendations be supported? What is needed from a community perspective to realize these recommendations that we demonstrated through this research?
Well, I'll begin. I don't have any brilliant answers because this is, we haven't tread that territory. And so we are working to create it and develop it and nurture it. And at this point, what we have learned is that we've got to go deep with our change, that we've got to bring people along and that are decision makers, that hold the decision making for money and allocation and power. And so the report in and of itself is a process and a product, and it is a tool. And so we've got to continue internally in the Oregon Health Authority to be sure that information that will change the system is exposed to that. And in that exposure, we deal with resistance. And so once again, we need to continue to work at a deep level, because we can't do a broad brush of ideas that don't really change and dismantle the current system, that don't really change the values and the attitudes that lead to the behaviors and lead to the systems that have created the problem. And so continuing to educate and continuing to help people feel, for lack of a better way of putting it, feel the pain, feel the change, and humanize that. I think Alfonso spoke about humanizing our cultures. The vulnerability in that is profound and necessary. And then within that, there's this, and I'm not really answering the question, I'm so sorry, but I'm this like train of thought is just charging out of my brain here. But one of the things that strikes me is that we are failing because we are breaking under the rigidity of the system. And the rigidity of the system is that which has been colonized and structured. And we have not tapped into the model of resilience in communities. And we've got to continue to break through that rigidity, because we're not going to be, we are we are cracking under our own weight as government in this. So I'm just going to stop there because I haven't really answered the question, except at this point in time, I feel like my responsibility is to continue to model, to push the information out there, to continue to make myself vulnerable in this, and continue to support my colleagues and community that are also very vulnerable in this.
Thank you so much, Leanne. I see Jackie's hand is up, so we are just a minute or so at time. Jackie, you have the last word.
Oh my gosh, I do not want the last word. I hope you all have like really amazing closing words. I just want to like kind of re-up what I was saying before about getting this amazing report out in front of different audiences, and I can help with some of them. It also occurs to me that it would be amazing for you to deliver this to a legislative audience, and and getting this to say it, like spending some time presenting this at House Behavioral Health, so that like you've got Rep. Sanchez in your corner, but there are other legislators who need to hear this message and to need to understand this more expansive idea of what behavioral health, mental health, just kind of community health is. You talk about reimbursement. Unfortunately, some of that is out of our control. Some of that is like, what can we get Medicaid to pay for? And so, or what can we get the legislature to say is Medicaid eligible? And I'm probably like butchering this, but like, traditional health workers became a category that could be paid for. And so there may be some statutory changes that would be made, but I think it starts with like exposing a lot more folks to just the real goodness and the richness that is in this report. So that's what I have to say. Happy to help in whatever way I can in the remaining time I have in the governor's office, which, end of December, I'm out. So with that, I'll turn it back over to you, Mara.
Thank you.
And it's because Governor Brown's term is ending. That's why.
Thank you, Jackie. I will actually give the last closing remarks over to Marcus, but before I do that, I did want to share with everyone that for everyone who registered, we will be sending a follow-up message that has a link to the reports. They're both in English and Spanish. We will also be uploading this forum onto YouTube, so we'll share that YouTube link with everyone as well. And with that, I will hand it over to Marcus to close us out. Thank you.
Oh, thank you, Mira. It's an unexpected honor, but this is great. Again, thank everybody for coming today. Thank you, OHA and the OEI team. Thank you to all our partners on the steering committee, all the presenters today. Please read these recommendations. Please try to enact them in your organizations. And I'll save my last thanks for the Research Justice Institute at the CCC. Dr. Lopez, Dr. Mosini, and Kanya Masibi, those three, in addition to all the people I just named, really made this happen. So I appreciate all of you and the stellar work product that's come out of this. And I hope this is a first step in some real change in behavioral health and linguistic and cultural health in communities of color in Oregon. So with that, you are released. Thank you very much. And thank you, Mira, and thank you to everybody on this call. Yeah.
Thank you, everybody.
Thank you so much.